Greetings, viewers. I am Andrew Agbaje, a pediatric epidemiologist from the University of Eastern Finland in Kuopio, Finland. And here is my friend, Justin Zachariah, my co-author, a pediatric cardiologist from Texas Children's Hospital in Houston, Texas. We are both interested in protecting the heart of children across the life course and understanding the totality of factors affecting children's heart. We are both collaborating in a scientific statement illustrating environmental exposure in pediatric cardiology. We understand that climate change is becoming so widespread, and we want us to understand what climate change is all about and how it relates to congenital heart disease. Justin, can you please tell us anything about climate change and its relationship with congenital heart disease?
I'd love to talk about that, Andrew. Thanks. And it was great working with you on this scientific statement. What we know is that congenital heart disease is the most common birth defect in humans. We also have animal studies and human epidemiology studies showing that maternal hyperthermia, as evidenced by fever, is both uncomfortable for mom, but also a risk factor for congenital heart disease in the future. When we shift to maternal hyperthermia, as evidenced through climate change measured as extreme heat day events, we know that these extreme heat day events are associated with congenital heart diseases like septal defects, outflow tract obstructions. This is especially true when those extreme heat days occur during the spring or the fall, so-called shoulder seasons, implying that moms have a protective mechanism when they're used to it, but when they get caught unawares, they're not able to accommodate to it. This is especially true when it's happening during specific developmental stages, because we know that the heart develops in the first 7 weeks of gestational age. And what we also know is that the inability to mitigate this exposure is related to sociodemographic disparities, underlining environmental injustice in this problem.
So, environmental justice is important. Does extreme heat interact with any other factors?
I'm glad you asked. In fact, climate change does interact with airborne pollution. When both are present together, there's an even higher risk of congenital heart disease occurring. Can you tell us evidence about airborne particulate matter and Kawasaki disease?
Kawasaki disease is the most common acquired heart disease in children. Kawasaki disease is also an inflammatory condition affecting multiple body systems, and it includes a dangerous dilation of the coronary arteries. But unfortunately, data on Kawasaki disease appears to be conflicting. While some do agree that airborne particulate matter is associated with Kawasaki disease, others do not. Some, especially from East Asian region, do report that there's an association between international tropospheric windborne pollution measures and incident Kawasaki disease. But as a positive control data, those authors also showed that some of these particulate matters were also associated with the incidence of asthma and reactive airway disease.
Oh, so that's very interesting. This same data shows that particulate matter being transported across the winds from one country to another was associated both with Kawasaki disease and asthma. Did childhood stage affect this association?
Yes. It is quite important to know that clinical exposure to disease do also affect how children present ultimately. So in utero priming towards postnatal inflammatory conditions such as Kawasaki disease is quite important. Justin, can you tell us about metal exposure and blood pressure during the rise in pediatric obesity?
Yes, this is an important concern. So let's set the stage with what we know. Starting in the late 1970s, pediatric obesity has exploded, almost quadrupling in number. In that same period, the proportion of kids with high blood pressure has also increased because of obesity. But at the same time, both in children and adults, the average population blood pressure has not increased and has in fact decreased over that time. Now, in adults, we know that this is used due to increasing use of blood pressure medications, but that's not true in kids because we don't treat a lot of kids with blood pressure medicine. So that means that something is going on in the population as a whole, especially in the non-overweight, non-obese kids. And what's interesting, this same trend is found in diverse regions around the world, including Northern Ireland, South Korea, and even the Seychelles.
So, are you saying that while the proportion of kids with hypertension have increased, counterintuitively, the population average blood pressure did not substantially increase and probably might have even decreased? Do you have any insight about the mechanism for this counterintuitive trend?
Yes, we do have data on mechanisms in blood pressure. If we decompose blood pressure into large artery effects in the conduit arteries and small resistance artery effects, we measure large artery effects as pulse pressure. And pulse pressure has increased in parallel with obesity. But at the same time, small artery effects, as measured by mean arterial pressure, showed a dramatic drop. Now, what we also know is the late 1970s is when lead mitigation laws setting lead level thresholds also occurred. And when you accounted for the amount of lead person by person, the drop in lead levels accounted for nearly 60% of the drop in mean arterial pressure. And this seems to suggest that environmental law may have had a health protective effect on blood pressure.
So environmental policy like blood lead mitigation may have also helped blood pressure as well. Well, so similar questions to you. Did developmental stage matter?
Yes. In fact, our own co-authors have published separate data showing that in utero exposure to lead appears to precede later childhood high blood pressure. Andrew, can you tell us about another ubiquitous exposure to endocrine disrupting chemicals and obesity-linked metabolic traits?
Absolutely. Endocrine disruptive chemicals. Well, for this statement, we limited to phenols, phthalates, perfluoroalkyl substances, and polyfluoroalkyl substances, also known as the PFAS. They are used in food additives, they are used in plastic, they are used in manufacturing, and quite present in more than 90% of Americans. Similar in several countries as well. Unfortunately, it doubles the risk of cardiovascular disease, mortality risk in adults, and could also be moderated by obesity and diabetes.
Wow, 90% is a very broad exposure. Are there any special ways that kids are exposed?
Yes. During the stage of pediatric population, we consider the in utero exposure, transplacenta exposure. We also consider the exposure during breastfeeding, and we also consider the exposure when children are growing up and they are playing. But this exposure alters the genetic aspect of these children as well as the epigenetics. The prenatal phenol exposure, for example, like bisphenol A, are associated with postnatal higher blood pressure, as well, especially in females. Phthalate has been found to associate prenatally and postnatally with blood pressure and also dyslipidemia, like higher low-density lipoprotein cholesterol, as well as reduction in high-density lipoprotein cholesterol. Our co-authors have actually shown that adolescents' rising cholesterol level has been associated with subclinical atherosclerosis. So obesity bidirectionally associated with worsening vascular dysfunction as well as insulin resistance. This vicious cycle of metabolic dysfunction, vascular dysfunction, and exposure to endocrine disrupting chemical appears to be of public health and clinical significance.
That's very interesting. Can you explain to us some of the nuances of analyzing these very ubiquitous exposures?
Well, it's quite challenging because children have small body surface area and as well as small body mass. And so some of these chemicals do have synergistic and antagonistic interaction. So we cannot actually comprehensively say how much do this exposure impact children. Phthalates account for 40% of plastic in medical devices. So paradoxically, imagine our healthcare center might be an integral locus for childhood exposure to phthalate and some of these endocrine disrupting chemicals. So healthcare professionals ought to be leaders in avoiding and limiting this exposure. Well, Justin, What can we take away having said all this?
Yes, in light of all this, we do have some takeaways, which is we need more data. We need more attention to the cardiovascular implications of these environmental exposures in children. We need more longitudinal data because as we collect this data, we're finding the signals are increasingly clear that these are dangerous exposures. We need more clinical trials on effective preventive approaches against these environmental exposures. And we need clinical trials on treatment of cardiovascular consequences of these environmental exposures. Watch and contribute to this space. On behalf of Andrew Agbaje and our co-authors Penny Joan, Heather Ryan, Leonardo Tresand, Shore Farzan, and Wei Peng, we thank you for your attention.
Thank you.